All right, welcome everyone. We're going to go ahead and get underway here. Thank you for joining today's webinar sponsored by the Agency for Healthcare Research and Quality, also known by its acronym AHRQ. This is Gabrielle Weber with AHRQ's EvidenceNOW Technical Assistance Center, and I will be the moderator for today's session on Building Better Primary Care, New Tools for Getting Evidence into Practice. Before we get underway, a few quick housekeeping items. All participants' audio lines are muted to reduce noise interference. If you're experiencing any technical issues, you can send a message to the webinar host using the chat icon in your webinar console. And to find that, you can hover your mouse towards the bottom of the main screen and select the chat bubble icon, and just make sure to select the host from the drop-down menu of participants when you send your message. Throughout the webinar, if you have questions about the content being covered, please submit them through the Q&A function. And to access that, you can hover your mouse again over the bottom of the main screen, select the icon with 3 dots, and choose the Q&A option from the additional options there. We'll have time at the end of today's webinar for the panelists to answer your questions. Lastly, today's webinar is being recorded and will be made available for download along with the presentation slides on the ahrq.gov website next month. With that, I'm going to turn things over to Jan Ginevro, Health Scientist at the Agency for Healthcare Research and Quality, to get us started with today's presentation. Over to you, Jan.
Thank you, Gabrielle. On behalf of the Agency for Healthcare Research and Quality and the EvidenceNOW initiative, I'm very pleased to welcome everyone to this webinar on Building Better Primary Care. Our speakers today include my AHRQ colleagues, Cindy Brock and Bob McNellis. We're also very pleased to have with us Ernesto Fana of the Primary Care Information Project and Healthy Hearts New York City, which is an EvidenceNOW cooperative, and also Julie Schmelzer of MedStar and Healthy Hearts in the Heartland, also an EvidenceNOW cooperative. Before we dive into the exciting information we have to share with you today, I'd like to do 2 things. The first is to quickly walk through the agenda for our time together today. And here you see the agenda. After this brief introduction, Bob will lead us through some background information on the EvidenceNOW initiative, which will set the stage for Cindy's presentation on tools and resources. Cindy will pass the baton back to Bob for a discussion with Julie and Ernesto about key resources and how Julie and Ernesto have used them in their work as practice facilitators. We'll then open up time for questions, answers, and discussion, so please keep your questions in mind as we move through the different presentations. The second item is to invite you all to subscribe to AHRQ's Primary Care Practice Facilitation Bulletin, an electronic newsletter that's designed to keep you in touch with practice facilitation news and resources, and also with other practice facilitators across the country and now around the world. Information on how to subscribe is presented here. We'll be repeating this information at the end of the webinar, and it will also be in the slide set that will be available to you, as Gabrielle mentioned, as it will be posted on the AHRQ website. And now I'm happy to introduce Bob McNellis for our EvidenceNOW 101 presentation. Over to you, Bob.
Great, thanks, Jan, and good afternoon, everyone, and thank you for joining us today. As Jan said, it's my job to give you the EvidenceNOW 101. So essentially, what you're saying is I have 5 minutes to talk about a project that has consumed the last 5 years of my life, for which we spent over $100 million, that employed almost 500 people, working with over 5,000 clinicians in 1,500 primary care practices that cared for over 8 million Americans. Is that what you're saying, Jan?
That is absolutely right, Bob.
Okay, no pressure, no pressure, but I better get rolling, so let me get on it. First of all, in a nutshell, EvidenceNOW is a grant initiative to help over 1,500 small and medium-sized primary care practices use the latest evidence on reducing cardiovascular risk by addressing the ABCSs of heart health. That is aspirin for people at high risk for CVD events, blood pressure control, cholesterol management, and smoking cessation, and thereby improve the heart health of the people they care for. Our 8 grantees are in 12 states. We have 7 implementation grantees, which we call cooperatives, and they are in New York City. They're in the states of Virginia, North Carolina, and Oklahoma. They're in the Chicagoland tri-state area around Wisconsin, Illinois, and Indiana. They're in the Southwest in Colorado and New Mexico, and they're in the Northwest in Washington, Oregon, and Idaho. Our 8th grantee, the little star out west, is the National Evaluation Team. While the PI is located at the Oregon Health Sciences University, their dream team is scattered across the U.S. Alrighty, so what are the goals of EvidenceNOW, you may be asking? Well, we have 4 goals. The first is to help practices implement evidence to improve healthcare with a focus on the ABCSs that I just mentioned. The second goal is to help build the capacity of those practices to receive and incorporate evidence in the future. And you'll sometimes hear us talk about PCOR findings. If we slip, that's patient-centered outcomes research findings. And we sometimes use the term evidence to describe that. It's much easier to say. The third goal is to learn about whether and how external quality improvement support helps primary care practices improve the way they work and improve the health of their patients. And fourth, and frankly the main topic of today's webinar, is to build and disseminate a blueprint of what works to transform care that others can use, and I'm looking at you audience, as they embark on their own primary care transformation efforts. This slide shows you the 5 core quality improvement services provided by the cooperatives to these primary care practices. They include data feedback and benchmarking, expert consultation, which you might sometimes think of as academic detailing, shared learning collaboratives, and health IT support, and perhaps most importantly, practice facilitation and coaching. We believe practice facilitation is the linchpin for delivering all these other services, or as we sometimes call it, it's the special sauce of our intervention. Here you're going to begin to see some of the findings. Now that we've been at this for a few years, we're starting to get some findings. And actually, I should change the title of this slide to learnings, because findings might be positive or negative, but learnings will always be positive. And so we are getting lots of learnings from EvidenceNOW. And over the last couple of years, we've posted many of these on our website with an eye towards early dissemination of the lessons learned. For example, here's just a quick screenshot of an infographic on the baseline ABCS findings at the patient level. Not for you to digest it, just to give you a sense of what we have if you visit our website. We've also looked at the baseline findings of how practices are doing with the delivery of the ABCSs, and you can see we're trying to shift all these these curves all to the right. You can find more about these on our website as well. We've also provided data on the characteristics of the 1,500 practices that are included in EvidenceNOW. And then here you can see we're really excited to begin to show these kinds of infographics, which show some of our actually real results. This one is the first of what we've begun to learn about how practices' capacity for doing quality improvement improved following the EvidenceNOW intervention. And then finally, for what I'll show here, in April, we published an entire supplement in the Annals of Family Medicine with articles from all 8 of the grantees and the AHRQ staff, and there were 2 terrific commentaries in there as well. If you read nothing else, read those 2 commentaries. You can find links to all of these materials on the EvidenceNOW website. And lastly, we've come a long way, baby, since we kicked off in May of 2015. This is the 3rd of our public webinars. You can find the previous 2 on our website. The grantees just gathered last week for our 4th annual meeting, and actually we're all still pumped about that. Now we're well into the analysis and dissemination phase of the project, and today we're going to talk more about dissemination of this blueprint. And to walk us through the wealth of tools and resources we've accumulated in EvidenceNOW, and let me just get that slide advanced here, I'm going to turn it over to my colleague, Cindy Brock, who's a senior healthcare researcher here at AHRQ and was instrumental in developing these materials. So Cindy, all yours.
Thank you very much, Bob. Well, I am privileged to be able to share information with you about this highly curated set of tools and resources. These have been nominated by our EvidenceNOW grantees, the practice facilitators who worked on the project, as well as AHRQ staff and our EvidenceNOW team here. And they're not specific necessarily to heart health, but they're really key to helping practices implement evidence. And the target audience for these tools are the practices themselves, practice leaders, clinicians, and other practice staff, as well as practice facilitators and other quality improvement professionals. So I first want to introduce those of you who are not familiar with the key driver diagram to what that is, because that is going to be very fundamental to understanding how our resources and tools are organized. So what you see here is this quality improvement tool that's used to display what needs to happen to achieve the aims of a practice improvement effort? So in the diagram, you have the desired outcomes, or aims, which are on that left-hand column in orange. And then you have the big changes, or key drivers, that are most likely to accomplish those aims. And that's our middle column here in green. And finally, we have specific change strategies or actions that have to occur to produce those key drivers. Now, one important takeaway from these diagrams is that to achieve practice improvement, you need to address more than one aspect of the practice at the same time. So practices are going to want to work on multiple key drivers to achieve their aims. So may I introduce to you the EvidenceNOW Key Driver Diagram. This has been developed over a period of many months as a collaborative effort between the AHRQ staff, our grantees, and our practice facilitators in EvidenceNOW. At the far left, you see the aim of EvidenceNOW that we're addressing, which is that piece that Bob spoke about building the practice's capacity to implement evidence. And the next column, you see our key drivers, and we have solidified these into 6 key drivers that we think are fundamental to driving that change. And in the next column, in the purple, are the change strategies that are associated with those key drivers. And finally, on your far right in gold, are the tools and resources that can help you make those changes. This diagram is interactive. So other than the aim on the far left-hand side, all of these boxes can be clicked on to get more information. So, for example, if you clicked on a key driver, you would get a page that would describe that key driver and also describe each of the change strategies associated with that key driver. If you clicked the heading on the very top of that column that says key drivers, you would get all of the drivers and their change strategies. But before I go on more about the navigation of the site, I want to talk through each of the key drivers briefly. The first driver is to seek, select, and customize the best evidence for use by the practice. And this is really very distinct to EvidenceNOW because it is about implementing the best evidence possible. So you need to start out with developing a process for looking for that evidence, whether it be doing some horizon scanning, going to trusted sources of information, and selecting the evidence that your practice is going to implement. Now, part of customizing that evidence can also include embedding it in information systems. For example, building in some clinical decision support so that there are prompts to deliver the evidence and to help make the decisions about who should get what kinds of information. And the final change strategy in this key driver is to inform patients, to let them know that you are an evidence-based practice and that what you are offering them in terms of treatment options are all informed by evidence. The next key driver is implement a data-driven quality improvement process to integrate evidence into practice procedures. And this is not so terribly different from other quality improvement efforts. You need to start with developing a quality improvement team, getting the right people on the team, including people who are actually making the changes that are going to be needed. You need to make some decisions from many different quality improvement approaches to choose, whether it's the model for improvement or Lean or Six Sigma or root cause analysis, and how you want to mix and match methods and the tools associated with those methods. You also want to choose some quality indicators, some quality improvement measures. And these are a little different from your standard performance measures in that they need to give you information about the progress you're making in implementation, as well as the impact on the changes that you're making. And finally, the engaged care team's change strategy is about the idea that quality improvement is not something that just the QI team does, that you need to bring the entire practice into that process. And we'll talk a little bit more about that in a moment. The third key driver is optimize information systems to extract data and support the use of evidence in practice. And frankly, this is one that our EvidenceNOW practices and practice facilitators really struggled with. And so we learned a lot in that process, and therefore we have a bunch of change strategies and tools associated with that. The first is identifying a data coordinator. This is a point person, not somebody who's going to enter all the data or run all the reports, but somebody to be a little more conversant with those information systems and make sure everybody is doing what they need to maximize those data. We also want to get the most out of our EHRs, and you know, I think a lot of you listening probably already know that EHRs are not necessarily designed to do quality improvement and population health. So we needed to coax those data out of EHRs. We need to have a EHR whisperer to be able to make that magic happen. And also to recognize when, you know, that there are other sources of data that you can use, and that includes registries. You know, trying to not beat your head against the wall if that's not working, but try other creative approaches as well. Involving care teams in this key driver is about making sure that the whole documentation process works. So that means, you know, is documentation being done in a standardized way so the information is where it should be? It also means checking that you're not overburdening staff with documentation tasks, and using those very knowledgeable care team members to identify when data don't make sense and perhaps uncover, oh my goodness, there was a mapping error that we didn't do that quite right. Because you need to focus on the data quality. People need to be able to believe that the data are in fact reflecting the care that you are delivering. Now, one very specific change strategy is in the information system to link patients with their care teams. And that's so that you can produce reports specifically for that panel of patients, so a care team can get the feedback on how they are doing with their own patients. On a practice level, it's a good idea to create a quality improvement dashboard, a small set of sentinel measures that can help tell you how you're doing overall. The next key driver is about creating and supporting high-functioning teams. And this is where the delivery of high-quality, evidence-based care happens. So, of course, the first change strategy is going to be to establish those care teams. And it's not prescriptive. There are lots of different ways in which the composition of the team can vary. But you need to really delineate what are the roles and responsibilities of each team member to make that clear. Next, you want to impanel your patients. This is the process, a very arduous process sometimes, of assigning the patients to their care teams. So in the last key driver, I talked about putting that linkage into the information system, but you actually have to decide who is going to be responsible for which patients, and to create in that team a sense of shared responsibility that we together are responsible for this group of patients. Empowering team members, sometimes that we are going to delegate certain tasks to team members that have not done that work before. We can do that perhaps with standing orders. That's one mechanism. But that we really need to have confidence that people are going to undertake and will be responsible for the parts of the care that they are assigned to deliver. Optimized communication, that can be done in huddles and other ways. And we really need people to engage in the evidence to learn new things that they may not have done before, and that may require some additional education. And the flip side of what I said earlier, that the teams really need to actively participate in quality improvement, look at those reports about how they're progressing and pay attention and figure out ways of improving. Key Driver 5 is one that really bubbled up from our grantees, that they really strongly asserted that you cannot be a practice that delivers evidence-based care and get good outcomes if you are not engaging patients. So the first piece of that is figuring out which are the patients that are affected by a particular piece of evidence and making sure that they are going to then get the appropriate care. It's also supporting patients in their own engagement in the care, whether that be by addressing health literacy or providing self-management support, and recognizing that support needs to come not only from within the practice walls, but outside in the community and connecting them to those resources. And finally, realizing that patients can be an important source of information for quality improvement work, whether it's asking for specific feedback or establishing patient and family advisors or even patient and family advisory committees. Finally, our last key driver is about nurturing leadership. And this is leadership throughout the practice. So starting with forging a vision of this is a practice that delivers evidence-based care and communicating that, to providing the support, the resources, the people that's needed to do that evidence-based care, to encourage learning and provide opportunities for learning about new evidence and new ways of delivering care, to be actively engaged in reviewing those quality improvement measures and really leadership showing that this is a priority with them, but also cultivating champions throughout the practice, not just physician champions, and really getting everybody on board to create a quality improvement culture, saying we are a practice where we are not afraid to identify opportunities for improvement, to make mistakes, and to learn from them. So I'm going to spend the rest of my few remaining minutes on showing you how to get around and access these resources. Let's say, for example, you wanted to look at all the tools that were related to key driver number 2. So you can see on the far left there that the tool and resource box is highlighted, and you see how it changes color, it gets darker, and it gets underlined, so when you hover over it, you know it's a link. And if you click on that, you come to this page, which is our sort of search function for our collection. You see that Key Driver 2 is selected, and therefore the resources connected with Key Driver 2 would be displayed. There are other ways of searching through these tools and resources. So for example, on the top left-hand corner, you see a search box. So you can put in a word or a phrase and search through the tools and resources that match that word or phrase. You can also look at specific change strategies and specific topics. And I will show you an example. Let's say you wanted to look at Key Driver 4 and just at the change strategy optimized communication. So you see on the left under change strategies, that is clicked off and you're only getting the change strategies connected with that resource. If you wanted to look at another change strategy, you would unclick that one and click one of the others that would appear. And the resources really span the gamut. There's a wide variety. So for example, here we have our team steps for office-based care, which is an entire online classroom training curriculum. Whereas we also have very short practice tools like this one on ground rules for communication among team members. And we have full implementation guides that give step-by-step and worksheets and resources to be able to implement a particular change. And finally, we have recorded webinars. So we are going to be launching this collection on October 1st, the first day of federal fiscal year 2019. And you will be able to get to it by going to the EvidenceNOW homepage, which you'll see the URL on the bottom of your screen. And you will be able to access not only the key driver diagram and all the resources connected with that, but we also have a whole section that's targeted specifically to practice facilitators and quality improvers to help you in the work of practice facilitation. And with that, I'm going to turn it back to Bob.
Great. Thank you, Cindy. Appreciate that. Well done. And, for those of you listening at home or watching the slide, I don't think that the screenshots are going to do justice what you're going to be able to do on this resource center. And we look forward to really that October 1 day when we can put it in your hands and you can let us know what you think about it. So here we are. Now you've heard a little bit about EvidenceNOW. You've heard quite a bit more about what we've learned and the tools that were used to work on EvidenceNOW and what our hope is to make them widely available. But I think what we'd like to do now is hear from some of the people who've used some of these tools in their work. And that's where we're going to have a conversation with two practice facilitators who worked on EvidenceNOW. The first is Julie Schmelzer. Julie worked with the Midwest Cooperative. She was in that group out in Chicagoland, and it was called Healthy Hearts in the Heartland. And you guys have a great logo, Julie, and I love the name. Since 2008, Julie's worked at Metastar, which is Wisconsin's healthcare quality improvement organization, in a variety of roles, including quality reviewer for the Wisconsin Department of Health Services and as a CMS project specialist. Prior to working at Metastar, Julie worked as a social worker for nearly 20 years with adult populations in both community and inpatient medical settings. Julie, welcome.
Thank you, Bob.
Yeah, sure. Actually, I'm thinking I appreciate your social work perspective. I bet it came in handy when working with practices, and look forward to hearing more about that. Also joining us today is Ernesto Fana. Ernesto worked with the Healthy Hearts New York City. Ernesto, I gotta say, you guys have a great logo too. I love the heartbeat of New York City is really what it is. And Ernesto is the senior manager of program partnerships at the Primary Care Information Project, which we just call PCIP. He manages a team that engages community providers and supports their practice by offering technical assistance with electronic health record optimization and facilitating modifications in patient care flow. Through past and current work, Ernesto has 15 years of experience in workflow redesign, quality improvement, and working with various electronic health record systems, such as eClinicalWorks. Ernesto received his Master's in Public Administration from the Metropolitan College of New York and completed a Practice Facilitation Certificate course from the University of Buffalo. So, Ernesto, welcome to you too.
Thank you, Bob.
And we've taken to calling you the EHR Whisperer. I love that term that Cindy coined, and so we look forward to hearing more about your experiences with that. So really, thank you both for joining us today. But I'll tell you what, to start off, let's set the stage for our audience a little bit first. So Ernesto, if you don't mind, I'll start with you. And first, can you tell us all a little bit about your work at Healthy Hearts New York City as part of EvidenceNOW?
Sure. As you mentioned, I work on the quality improvement team within the New York City Department of Mental Health and Hygiene. And just a little bit about our EvidenceNOW intervention. Our quality improvement support was provided by 16 practice facilitators and was delivered to 257 small independent practices across the city of New York. In combination, the practices had over 500 providers and 500,000 patients. And generally, each practice received 1 visit per month.
Great. Thank you. Great background. And I think one of the things that we know about your work in New York City is it's remarkable how small those practices really were. You worked with a lot of onesies and twosies, I think, in practice. Is that right?
That's correct. Yeah, we call them small mom and pop shops. It's really small stuff.
And I think, people don't often think about that when they think about practices in New York City, but really they're the bread and butter or the backbone of primary care in New York City, and I appreciate your work on that. Thank you. And Julie, how about you? Tell us a little about some of the work that you did with Healthy Hearts in the Heartland as part of EvidenceNOW.
Sure. So I had the privilege of working on EvidenceNOW, as you mentioned, as part of the Midwest Cooperative, or Healthy Hearts in the Heartland, also referred to as H3. So this cooperative was led by Principal Investigator Dr. Abel Coe of Northwestern University in Chicago, and it consisted of 10 different health-focused organizations located within the 3 states of Illinois, Indiana, and Wisconsin. And so as an EvidenceNOW practice facilitator in Wisconsin, I had the opportunity to travel throughout the state and work with a variety of both urban and rural, small and medium-sized primary care practices on implementing the evidence-based interventions to improve patient cardiac health of EvidenceNOW. And I will add that because of EvidenceNOW, I had the opportunity to learn about a large variety of electronic health records in our state that were being used in our state. I was able to teach quality improvement strategies to practice staff and also celebrate the success of the hard work that practices put forth because of participating in EvidenceNOW.
Great. No, thanks, Julie. And I just say I had the pleasure of joining you for a site visit to one of those small practices in Wisconsin. It was a little 2-doc practice, husband and wife team, Plymouth, Wisconsin, population 8,000 maybe, right? And they were amazing in what they could do, though. The capabilities they had for doing EHR, looking at data, and doing QI was pretty amazing. Would you say that's probably not typical of the kind of practices you work with, though?
Right. They by far were a high-achieving practice, but also worked with a lot of other great practices in Wisconsin. So.
Yep, absolutely. Well, that's great. Well, thank you. Thanks for sharing some of that work. So let's talk a little bit about tools, though. And Julie, actually, maybe I'll start with you for this one. Can you tell us a little bit about how you might typically introduce tools to the practice? And what I'm thinking of is, are there some types of tools that a practice will or won't want to use, or are there some that are an easier sell than others? How do you go about getting practices to engage in sort of using tools to improve their quality?
Sure. So the first part of your question, how I typically introduce tools to practices, I like to take the approach of sort of gaining a better understanding of where the practice is interested in directing their focus related to the project or the initiative that we're working on. And so then once I know a little bit more about that, I will suggest a variety of tools that match their focus. And always trying to be mindful that the practice may not agree with what I believe to be the most helpful tool. So I have found by offering a variety of tools, the practice gets a choice, and we talk about that tool and how it relates to their current focus. Everyone likes to be listened to, so it's important to be respectful of what tools the practice wants to try first. And certainly I would never try to force a tool on a practice team, and instead I try to provide concrete facts about why I believe a tool would work well for the current project. And then of course try to have try to be open and listen to why the practice staff may feel differently than I do about a certain tool. And just another helpful way that I have found to introduce a tool to a practice is to explain a successful experience with that tool while working with a different practice. And I think we all find value in modeling the success of our peers, and even though that isn't going to necessarily make a practice jump on board and use the tool just because another practice found success, I found this provides a reliable way as a practice facilitator to show the value add from a specific tool. And I will just add that as far as types of tools that practices will or will not use, I think this is based on what the practice has experienced in the past when adopting a new tool, and whether that was a positive experience or a burdensome experience. By burdensome, maybe was it taking up a lot of staff time, or maybe presenting too many challenges to the staff. So in my experience, the tools easiest to sell are tools created or recommended by reliable, well-founded health and research organizations, such as the Agency for Healthcare Research and Quality, or the Centers for Disease Control and Prevention, the Institute for Healthcare Improvement, the American Medical Association. And since EvidenceNOW had a cardiac health focus, tools created or promoted by the CDC's Million Hearts campaign or the American Heart Association always seemed to be really well received by the practices that I worked with. And just to close with my experience with what tools will not work with practices, those tend to be tools that are maybe too complicated, or tools that may affect other well-run processes. You certainly don't want to mess with something that's working well. And as a practice facilitator, if I cannot explain a tool in an easy-to-understand concept, chances are that tool will not be very well received by the staff that I'm talking to at the practice. So explaining your tools well and allowing time for questions always seems to be greatly valued by the practice. And I will just add that any time the practice staff believe that a tool places the practice at a true or perceived risk of maybe a breach in practice, in patient protected health information, or PHI, you need to stop right there and pause and take the time to listen to that concern and provide facts and information and any reassurance needed so the practice doesn't believe you're trying to introduce a tool that could affect PHI. And so just in summary, really know the tools that you're sharing with the practices, know them in great detail, be open to the team's questions and suggestions about a tool, and just talk it through with them and work on that together for better understanding.
Yeah, great answer, and lots of great things in there, Julie. And I definitely heard your social work perspective coming out there about listening and explaining. Really nice, and I think it's really helpful about the storytelling part. And there's certain competitiveness I suspect that practices have, and so using that as well, and great cautions about what kinds are helpful, or great advice about what's helpful, and cautions about what's not. So thank you for that. So Ernesto, hey, I'll just start with the sort of same question to you, and I'd love to hear your perspective about how you might introduce tools and what kinds you have found to be helpful or not helpful for practices.
Sure. The success of a tool relies heavily on the way it's framed during introduction. So what we typically try to do is to frame the tool as a solution to a problem, and then showcase how the tool that's being introduced can solve a problem or several problems on the practice level, ultimately making life and work a little more efficient.
Great. No, thanks, Ernesto. And I mean, do you take Julie's approach too? You think tailoring is really an important part of what you do? Is it important to sort of really listen to what the practice is interested in?
Absolutely. I mean, I think when we're engaging in this type of work, there's a set goal and plan, but we have to, I guess, kind of taking the social worker's perspective, meet the practice where they're at, and pretty much go at their speed and meet their expectations.
Yeah, and that's a great phrase. I've heard that a lot in some of our work with practice facilitators, that meeting the practice where they're at is really critical, and having the right tools that meets them where they're at sounds like that's really important. Well, so maybe Ernesto, let's build on a little bit of what you said here and maybe get a little bit more specific. Are there some certain types of tools or resources that you found particularly helpful as you were working on EvidenceNOW?
Sure. So two resources related to Key Driver 3, just to remind everyone, which is to optimize health information systems, that really helped us guide our work during the intervention were the use of dashboards. Specifically, in our case, the use of what we call the panel summary report. There it is.
Yep. I just happen to have it ready to go, Ernesto. Amazing.
That's wonderful timing. So I'll continue to answer the question, and then I'll kind of give a quick summary of what's on the report.
Great.
The panel summary report really showed progress or lack thereof from month to month. It also highlighted which patient panel within the hypertensive panel the practice should focus on to improve. So aside from the panel summary report, we also utilized the reporting mechanisms within the electronic health record, which in this case for clinical works was the registry and EBO reporting. So we used those two things in conjunction because the panel summary report offers aggregate data, but it doesn't identify who exactly those patients are. So part of the workflow for the practice facilitators while on site is to use the EHR to identify those patients. On the panel summary report, we're looking at the practice's entire panel of hypertensive patients, which is broken down into 4 categories. So we have stage 1 hypertensive, stage 2, controlled, and then we also have a section for patients that have undiagnosed hypertension, which just means that they have their last 2 blood pressures were elevated and there's no hypertension diagnosis. 9 out of 10 times there's a good reason for that. Maybe the patient was sick during the visit, but we just want to bring that to the provider's attention. Within those 4 categories, there's 4 points of data. So basically for each category, you'll be getting the number of patients seen within the last month, number of anti-hypertensive medications prescribed, number of patients that are voice-enabled, and number of future appointments scheduled at point of care. So you're getting 2 look-back periods. You're looking at last month and the last 12 months. And the workflow behind this report, it's usually emailed to the provider, and while on-site, the practice facilitator will review the data and then go into the electronic health record to generate lists of patients that need follow-up.
Very cool, very cool. Do you want me to pull up the registry also? Do you think that would be helpful? You want to talk a little about that?
Sure. So the panel summary report is on the front, and this is what you'll find on the back side of the report, and it's just a workflow for providers to follow if they wanted to use the registry to find the patients that are depicted in the panel summary report. And we find this especially usual because I don't know if other cooperatives have had this issue, but in New York City we had a high turnover ratio at small practices. So it's like you train staff 1 month, you go back the next month and you have new staff and you have to do it again. So this is just kind of like a good cheat sheet to kind of keep the work going.
That's great. No, thank you, Ernesto. This is really good stuff. And part of the reason we should tell folks that we've included these 2 examples, I think, also is because your whole tool from New York City will be part of the blueprint. We'll have that available for folks so they can see it. And while these 2 tools were sort of related to heart disease, I suspect these could be adapted for other things as well. Do you think?
Sure. Yes, they can.
Yep. Well, great. Well, thanks for highlighting those 2. Those are 2 great tools that you used, and I could see how practices could really benefit. And actually, you've really primed me with the whole turnover thing, having to reteach every time. It's great to have that as a sort of recurring tool that you can use every single time for consistency in the practice. Fantastic. So, Julie, same question to you. Did you find, were there some resources that you found particularly helpful that you might want to highlight that we just might happen to have a slide about, that you might want to mention?
Sure, Bob. And I'm no EHR whisperer like Ernesto, but I found his tools very interesting here to see. And so tools that I, kind of pulling from what Ernesto said too, tools that I found most helpful on EvidenceNOW certainly are any tools that are easy to implement and easy to measure for success by the practice staff. But kind of the gold standard, or something that I found very valuable in my work on EvidenceNOW, included the AHRQ Practice Facilitation Handbook and the Practice Facilitation Curriculum modules. These were tools that I could refer to, for lack of a better term, when I was stuck and quite didn't know how to proceed with a particular area that I was working on with a practice, or if I needed a refresher or a reviver idea or approach with a practice, I could go to these resources and get unstuck. So really valuable variety of tools and resources identified within modules and the handbook. So really found value in using that on EvidenceNOW.
That's your second AHRQ plug, Julie. Just so you know, we're applauding you here at AHRQ because you plugged us twice. So thank you very much for that.
Sure, sure. I should have done like the no solicit, you know, whatever. When I'm not promoting anything intentionally here. So. And so I would just add 2 other widely used quality improvement tools that I used for work on EvidenceNOW and on other projects include the Model for Improvement and the Plan, Do, Study, Act documentation tools. You know, I think there's a variety of Plan, Do, Study, Act tools available, and some practices, especially if you work with a practice from a health system, they have their own version of a tool like this. So you certainly want to use a format that they're going to be most familiar with and be willing to use. Typically depends on your group, but I would suggest being open to different types of documentation for the Plan, Do, Study, Act tool. And the Model for Improvement, I kind of leave that as a leave behind because we review it and then it's just something that people can refer back to. And last but not least, because I'm kind of social worky, I will add that whenever I'm engaged with a practice or a clinic group or staff, I have found the ORS Communication technique, which is part of motivational interviewing, to be very helpful. And as you can see from the slide, ORS, O-A-R-S, stands for using open-ended questions, affirming those answers, and using reflective listening skills, and then summarizing what you have heard from the group. So very valuable and helpful when talking with practices and modeling that so practices and staff can use that with patients as well.
Great, thanks. I know, Julie. You know, as a clinician, I've found motivational interviewing really important to get at patients' needs and their goals and things like that. So I can see it makes perfect sense. It would also work when trying to change behavior, or understand the needs and goals of practices as well. So I love to sort of that analogy about how practice facilitators or doctors for practices, I think, is a really cool one. Well, that's great. Well, thank you both for highlighting these resources. And just to let folks know, really, these are going to be part of what's in that blueprint, that repository of the tools and resources that we've developed. And when they're launched, we look forward to you exploring these and others. But what I'm curious from you, Julie and Ernesto, and Julie, I'll start with you in this case, is I'd be curious to hear a little bit about, and hopefully our audience would as well, about how you're using what you learned from EvidenceNOW and H3 in other projects. Are there things that you've used that you find you can use in many different things moving forward?
Sure, of course, and what comes to mind right off the bat is I would start out by saying I really try to model the strong collaboration that was present on EvidenceNOW, especially among my own cooperative. If you recall, I mentioned that the Midwest Cooperative consisted of 10 different health-focused organizations, and we were from 3 different states, and we were all working together in order to contribute to the success of EvidenceNOW. And you just can't even imagine the support and knowledge that I was able to gain from my colleagues. And so really try to model that on other projects that I'm working on. Whether your office mate is in the office next door or in the next state, you can certainly try to foster that collaboration. And again, this is probably another plug for AHRQ, but the tools and support that was available through EvidenceNOW through the Practice Facilitation Learning Committee and the listservs were really invaluable to help foster that collaboration. And I guess another part of EvidenceNOW or Healthy Hearts in the Heartland that I try to model on other projects would be this is based on what I heard from some of the practices I worked with, that trying to model the approach of going in person to work with practices whenever possible. And I know that's not always possible depending on the project you're working on or how it's funded, but really try to model that approach because it's not the most popular in today's technology-focused world, but that in-person visit, although it can be rare, it can be really valuable. And as long as you're providing the beneficial information and resources that the practices are hungry for, which EvidenceNOW did, I think that's a really great thing to use on other projects.
Great, thanks, Julie. So Ernesto, how about you? You found that some of what you've learned from Healthy Hearts in New York City and EvidenceNOW is helping you, or at least you're using some of that as you work on other projects?
Absolutely. I couldn't agree more with Julie's last point. One of the takeaways for us has been human contact despite tech. I know with the introduction of so much technology, things become easier and more automated, but I think the practices that we worked with really appreciated having someone there and having someone guide them as a practice facilitator or coach. We've also found that providing constant feedback and showing improvement or showing no improvement really motivates providers and staff to engage in the quality improvement process. And we've also found that the ongoing training that we provide is important because of the turnover issue that I spoke of earlier. So we have moved forward and implemented those things into our current and future work.
Yeah, that's great. And actually, one other thing, you know, when we had some of our initial conversations, Ernesto, we talked about how you're helping sustain some of the gains. Anything you want to say about that? Is you know, the work that you're doing? Because I think that's just critically important about this. How you sustain the work that you've done and some of the improvements that you've made with practices. I'm sure you've thought about that a little bit. Do you have anything you want to offer about that?
Sure. You know, one of our focal points is to have high performers maintain that high performance post-intervention. So we've really worked hard with staff on training and implementation of workflows and kind of making things that seem difficult easier. And some of the things that we've introduced are reports. So a lot of the work that we introduced relies heavily on patient list generating. There are certain systems within the EHR that require several clicks in order to generate an adequate list. One of the things we did was introduce a report type where it's just one click and the report is generated. So little things like that that make things faster for the busy staff really help a lot and go a long way for sustainability.
Well, that's great. No, thanks, Ernesto, for helping with that. And I know, actually, I also appreciate your other point. We sometimes are forced to make a choice between high tech or high touch, and it sounds like what we're saying is you need both. You can have high tech, but having the touch as well, building those relationships, critically important. So that's really great. Thank you for those insights. There was one other thing that I noticed, and for folks who are listening at home, the cross collaboration between cooperatives was also, I think, really important and one of the strengths of this project. And Julie, you were mentioning that you were looking for some Spanish materials at some point. Do you want to tell me just a little story about that particular connection?
Yes, that's a great story for this because it involved Ernesto's cooperative, and I actually was working with a practice that requested some customized documents for our cholesterol measure in Spanish, and I was struggling finding them, and I put out a request out on our EvidenceNOW listserv, and the New York Cooperative responded with some fantastic materials that I was able to share, and I would have never, you know, been able to locate. I think they were created in the state of New York, and in Wisconsin it was very valuable to have those. So great connections and really easy to get those resources efficiently.
That's great. Thanks, Julia. I know I was struck by that conversation, and you guys did have a strong team. And the way that we've tried to continue this a little bit is by right now we have our newsletter out there, and all we don't have an active sort of group that meets regularly. I do put out a monthly newsletter that focuses on practice facilitation and practice facilitation issues, and we'll give you, again, I know at the front end we gave folks an opportunity to sign up, and frankly the easiest way to sign up is to send me an email, and you'll see that on the slide. But also, this has been a fantastic conversation, but I want to just sort of try to wrap it up a little bit, but make sure I turn back to you. So Ernesto, let me start with you. Anything that you wanted to say today? Any final comments you want to make before we close out this conversation?
I think the lessons learned through this intervention are so valuable, and we should continue to keep this work going because, especially in the primary care sector, they need all the assistance that they can get. They really do. Yeah,
appreciate that. Thank you, Ernesto. Julie, how about you? Any final comments?
I would just say that I'm really excited about the key drivers and the resources that were shared by Cindy, and They're going to be provided to us on October 1st, so I think that'll be really valuable for any practice facilitators working with primary care practices. So thank you for that, Cindy and AHRQ, and I know it'll be a really nice product and looking forward to using it.
Great. Well, what a great conversation. Thank you so much for joining us today to share your insights on some of these tools and how you work. So thank you, Julie. Thank you, Ernesto. And now to facilitate the audience Q&A, I'm going to turn it back over to you, Jan.
Great. Thanks, Bob, and thank you again, Julie and Ernesto, and I hope that you can help answer some of the questions that have been coming in from our participants. One of the first questions has to do with and I'm opening this up to Bob and Cindy also, is how important you think it is for practices or teams to be able to pull their own data for quality improvement work. So there are a lot of different ways that data can be extracted. One of them has to do with teaching, we call it the teach-to-fish model, in which practices are being trained how to do this on their own. But Cindy, let me turn to you and hear what you have to say about the pluses and minuses of different data extraction methods.
Well, and that was a phrase that was actually used by one of the EvidenceNOW grantees at our meeting last week, Michael Parchment from our Northwest Cooperative, who really believed in the teach-to-fish. So the idea that the facilitators would not be pulling the data for them. Now, this question, though, was about the quality improvement team and whether the quality improvement team, does that on their own, or does everybody need to do that? And I think, it really, of course, is going to depend on the size and structure of the practice. So one of the things, though, that we have seen emphasized is the importance of sort of cross-training or getting people to be able to cover for each other, and that idea that one person should not be the sole one who knows how to do that. And as Ernesto mentioned, that once there's been some heavy lifting in terms of being able to program it, then you make it so anybody can actually generate and pull the reports very much more easily.
Great. Ernesto or Julie, do you have any comments that you want to share in relation to that question?
This is Julie. I would just add to what Cindy said, that I think it can be really valuable for sustainment to have that understanding of how to pull data from a practice, because we worked with some practices who really didn't know all of the capabilities of their electronic health record or how to pull data. So I think there is great value in that. But it is a loss if it's only one person and then there's that shift in staffing. That can really be a not so good thing. But I think it's always good for practices to know as much as they can about the data in their EHRs.
Great, thank you. One other question that's come in, and I think Julie and Ernesto, this might have been for you, is whether you could provide examples of some tools that have been poorly received and provide a little bit of insight into why you think those tools were not well received by the practices. Sorry to lob that one at you, but can you think of a particular tool that a practice really resisted, or they found it hard to use?
Sure, I have an example. Not necessarily resisted, but because of the way it was built within the system, it was some of the practice staff would forget to use it. So we built a medication adherence template within the system so that during triage, a patient can be asked 4 questions to kind of gauge how well they're taking medication, and depending on how the patient answered those questions, the medical assistant would kind of alert the provider, oh, this patient might benefit from an adherence counseling session. So at the beginning, it went fairly well because we kept reminding them, but what we found was that as time went on, it was within the system, but it was very manual. There were like 4 to 5 clicks. They kind of stopped using it. So I think if we kind of rethought that process and made it a little more automated, it would be better received.
Great, thank you, Ernesto. Julie, any examples that you can think of that might pertain?
The only thing that I can think of off the top of my head is I tried to introduce a newer telephone app for ASCVD risk calculator, and you know there's quite a variety of those out there, and this particular practice had a provider who really embraced a certain app for that risk calculator, so they really wanted to follow what their colleague was using within the practice, if that even makes sense how I'm explaining that. But it was trying to introduce maybe a new variety of a tool that they already were using and they were finding successful. So a new way or a new tool was not welcomed in that situation.
Great, thank you.
I just want to remind people that we have another 15 minutes, so please continue sending in your questions through the chat function.
Thanks, Cindy. So this is a question that's specifically for you from a member of our audience. Did most of the small mom and pop practices with which you worked have EMR capability to create patient registries for identification? The audience member has heard that these EMR capabilities cost extra, so how was this obstacle overcome?
That's a great question. So we have a little bit of a unique situation here in New York City. I would say 95% of the practices that we work with are all on the same EHR, which is eClinicalWorks. So for us and the other 5% are on another EHR MDLand, and both have built registries. So for us, that really wasn't an obstacle.
Great, thank you. Julie, any thoughts that you'd like to add about registry capabilities in your practices, or was that not something that really was an issue for you?
Well, somewhat of the flip side of what Ernesto said, in Wisconsin, I think we worked with 20 practices on EvidenceNOW, and there was 14 different EHRs that we were working with. So very different when there is such variability is what I would add to that.
Right, huge challenge. So this is a question that I'm going to open up to Bob, Cindy, and to you, Julie and Ernesto. Were you able to help practices communicate with each other and share effective strategies? And if so, was that helpful? And Ernesto, I know that in New York City there were you did have some activities in which you tried to bring the practices together to communicate with each other. Maybe you could tell us a little bit about what that was like for the practices and whether you thought that was helpful to them.
Yes, so we actually did host a few learning collaboratives, or learning clusters as we call them, between practices that were in close proximity to each other. And what I found was that it was very helpful. I'll give an example of one provider that I was trying to get him to adopt visits just for blood pressure monitoring. So the scenario goes, if a patient showed up with an elevated blood pressure, you know, the provider would ideally schedule him to come back in 2 days just to get his blood pressure read. And if the blood pressure continues elevated, then he would be seen by the doctor. If not, it would be documented, and then the patient would go on his or her way. One of the providers that I was working with didn't want to do this because he was afraid that his practice didn't have the bandwidth to handle this. He has a very small waiting room. So I had a mix of providers, some that did adopt this visit type, and then this one that didn't. And from hearing the success stories of the ones that did, he was able to change his mind and see that, you know, maybe I should give this a shot. Maybe it can be effective in my practice.
Yeah, that's great, Ernesto. And this is Bob, and I'll just share from the broader EvidenceNOW perspective. I know of at least 2 of the cooperatives that really tried to bring practices together. So in Virginia, they had, at the launch of the initiative, they had these, I call them big tent meetings. They bring everybody in, get them all excited about the project. The practices would sit together and go through some presentations, including some things by the Sinskys, who really promoted the joy in practice piece. The challenge, I think, for them was, number one, is getting practices to show up. And then how to engage them after the meeting was over, I think was some challenges that they're still trying to figure out what the effect of that was. in the Southwest, both in Colorado and New Mexico, they also had practice meetings where they brought practices together on a periodic basis, again, to share practice, what had worked, lessons learned, things like that. And again, although I think it worked at the meeting, it's not clear to me anyway whether there was communication in between times. And I think the biggest challenge they would have is just practice is so busy.
Mm-hmm.
They rarely have time to learn from themselves, let alone to learn from each other, even though folks have tried to do that.
And one additional cooperative, the Healthy Hearts Northwest, which was the cooperative that provided services in Washington, Idaho, and Oregon, also had multiple different strategies for bringing practices together to learn from each other. So Cindy, we have a question about internal and external sources of evidence for practices to use. Could you provide your thoughts on that?
Sure. So, so the evidence that was used in EvidenceNOW was evidence that had been come out of the patient-centered outcome research and was external to the practices, that the practices were presented. This is the state of the art of the evidence, and they then took it upon themselves to actually try and implement that. In general, with these smaller size practices like the ones that we were working with in EvidenceNOW, they are looking for sources of evidence outside. And in fact, one of the tools that is in the collection talks about, trusted sources of information, because there'll be lots of guidelines out there. Not all guidelines are created equal, and how do you kind of winnow out the chaff? But the other point to make here is that a lot of these tools are very applicable to larger healthcare organizations. And when you're dealing with big health systems, they are, in fact, a number of them trying to be learning organizations, and they are producing evidence and finding better, looking at their own variation within their systems, finding better ways to deliver care, and then trying to spread that within their own system. So that's a case in which they're producing internally the evidence that they then still have to struggle to implement.
Great, thank you.
And if I just might offer, so actually, great question, and last year's public webinar was really about learning health systems and about how EvidenceNOW was in small practices working to build learning health systems that would use both external and internal evidence to help guide their clinical decision making. So really great point.
And we have another question that specifically deals with federally qualified health centers and larger organizations. And this question says or asks about larger organizations like FQHCs that use multiple tools and data sources. How do you promote the use of one centralized tool to avoid confusion and maximize optimization in such an organization in a short amount of time? Large organizations require buy-in from leaders and the clinical teams that use them. So how can this problem be addressed? So Cindy, let's start with you, and then we can get...
Yeah, well, this takes me back to the predecessor project for EvidenceNOW, where I worked with Lindy Knox and LANet out in California with about 20 federally qualified clinics. And some of those clinics were part of larger systems. And they found it much more difficult to kind of turn on the dime. They had to do a lot of floating things up to getting approval, to changing a patient handout, or trying to get a report out of their information system. And so I think that you have to recognize when the practices you're working are part of a larger organization that you need to also work with the leadership of that bigger organization and get them on board. I also would, literally question whether or not everybody has to use the same tool throughout an organization, that you don't want to stymie what is creative use of and existing energy towards that quality improvement activity, but there are certain things like how you're doing documentation or the roles on this team that are important to standardize because, you know, when a team member is out and somebody else needs to take over for them, you really want it to be able to be done the same way.
So Bob, Ernesto, or Julie, any thoughts about the challenges and benefits, perhaps, of working with larger organizations?
I'll just show why Ernesto and Julie are thinking. I'll just say, you know, the one thing about EvidenceNOW is we really targeted small and medium-sized practices, so 10 clinicians or fewer. And I know, as Cindy's mentioned, we've worked with larger organizations, and the questions are a little different. I'm not sure we have the learnings from EvidenceNOW to help inform that, but it's a great question, and certainly maybe that's another phase of work for us at some point. Thanks, Ben.
Yep. Julie or Ernesto, any thoughts about working with larger organizations?
This is Julie. The federally qualified healthcare centers I worked with on EvidenceNOW were small, as Bob just mentioned. But I will say just fantastic staff and really willing to embrace projects once they were recruited and leadership agreed to work on the project. So I don't have any experience to pull from large federally qualified healthcare centers, though.
But thank you, Julie. So the next question is, what are best practices for staffing this initiative? In other words, how many hours per week would be needed per practice involved or other metric to help determine the staffing needed? And let me preface any answers to this by saying that across the 7 implementation cooperatives or grantees, there were a variety of models that were used, both in terms of the number of hours of direct contact, the number of hours of virtual contact, the duration of the interventions, and overall the number of touches, as Bob mentioned, that the practice facilitators had with the practices with which they are working. But I will turn it over to others now to talk about specific thoughts about staffing.
Yeah, and I'll just kill a little time while Ernesto and Julie, you sort of think, because you guys are on the ground and you know what you deployed in order to run this. But I will just sort of echo Jan's comments that there was a wide variety of different models for this, and I'll just highlight a couple. And one is that you know, there was a model. The model used in the Southwest was they used a tripod model that had a practice facilitator, a cheetah, best name for health profession ever, certified health IT assistant, and then they had a regional health connector. So they had 3 different pieces of people who would go into practices to try to pull together the community part, the electronic health record part, and then the QI by the practice facilitator, and that there are many different models for doing this. So the staffing needs may vary depending on what kind of model you adapt for doing that. So I'll just leave it at that. And it looks like maybe Cindy want to add something, and then we'll turn to our PF.
Well, yeah, again, this is stuff that I learned from the cooperatives at last week's meeting, but one of the interesting things looking across the cooperatives was they varied on how they distributed their hours. So some did in-person meetings and some did remote, and sometimes those were substituted for each other, and so that there were stronger doses where more hours and more intense. But in fact, across the cooperative, so all of these different practice facilitation efforts, it was a similar amount of hours spent with each practice, and it was relatively small. And so I'm trying to remember the exact figure, but I think that they were talking about a couple of hours a month with each practice.
So we're approaching the end of our time together, and there are many other really good questions that have come in. We're going to save these and give them to Bob. So as editor of the PCPF bulletin, we're going to try to get answers to these questions and distribute them through the bulletin. I also wanted to encourage you again to subscribe to the bulletin. The information is on your screens now, but as Bob said, it's probably easiest just to email him directly at robert.mcnellis@arc.hhs.gov with a request to subscribe, and he has also very generously offered to be a contact person for questions that you might have that arise after the webinar. So any last thoughts from any of the
I'm just thinking from Julie and Ernesto in particular,
Right.
you guys have any last things you want to offer on any of those things?
This is Julie. I was just going to say on that last question, I think geography is a big factor on time for a project such as this. I mean, I think Ernesto probably, I think he told me he walked to a lot of his practices in New York City, and we had a lot of time spent in vehicles in Wisconsin. So it just depends on where you're located too, where the practices are located.
I think that's an incredibly important point. I know that some of the practice facilitators had to cross mountain ranges in the snow and spend hours getting to their remote rural practices. Ernesto was able to walk. We had a wide variety of situations. One quick thing before we conclude the presentation, I do want to mention that in addition to the tools and resources that are related to the key driver diagram, there are two other important elements of resources that we're going to be posting as part of this Blueprint or Resource Center. One has to do with the evidence, the P-Core evidence that was used as the foundation for EvidenceNOW, evidence related to cardiovascular health, and so we'll have all of that, a repository of the evidence that was used, and we'll also have information for primary care researchers. We'll have information about the research design of all of the cooperatives and the national evaluation methods, measures, and lessons learned from the process of implementing this study. So in addition to practice facilitation tools and resources, we have a variety of other learnings that we will hope will be helpful to the larger primary care clinical and research communities. And with that, I just want to say thank you so much to Julie and Ernesto for joining us. Your information has been invaluable, as has your participation in this project. I want to thank Bob and Cindy for their presentations, and also the representatives from our Technical Assistance Center for making this presentation possible. And also thank you all of you who took the time to participate in this webinar. We're so happy that you could join us, and we look forward to you coming to our website now and also on October 1st with the big launch of the EvidenceNOW model for improving primary care. So with that, Gabrielle, I'll turn it over to you for any last thoughts or logistics, and we'll take this opportunity to say goodbye.
Great. Thank you so much, Jan, and everyone. As Jan mentioned, if you're interested in more information about EvidenceNOW, you can visit ahrq.gov/evidencenow. And as we mentioned at the beginning of the webinar, the slides and recording of today's webinar will be made available on that same website, so ahrq.gov/evidencenow. And again, just a huge, huge thank you to all of our speakers, Jan, Bob, Cindy, Ernesto, and Julie, and to all of you on the line for joining us today and for sending us your great questions. So that concludes today's webinar. Have a great day, everyone.